evening, we're fortunate to have two physicians with us. And just to briefly let you know who they are, Marcus Williams is a cardiologist with Horizon Cardiology. And I neglected to find out how long he's been at Valley, but I know it's been many, many years. And Traci Burgess is one of the high-risk OB physicians at Valley. She's also the assistant director of maternal-fetal medicine, and she's been with Valley for 10 years. So without further ado, it's my pleasure to introduce to you Dr. Burgess.
Thank you. I'm going to share my screen. I'm sometimes new at doing some of this, so bear with me for one quick minute. Ms. Lucas, do we see the slides?
Not yet.
Not yet. Okay, so let me do this. Show. That. Share screen. And now?
Nope.
No. Oh.
No, it was on before too.
And from my end, it looks like it's on. Okay, hold on one sec. Let's go.
You have two monitors, maybe?
I do have two monitors. Let me see. Let's try this one. Okay. Do you see anything now?
No, it's the same.
Okay, all right. Let me see, I'm going to go out again. So I'm going to do share screen. I can't believe we practiced and now
I
it's...
know. That's okay. It's just giving people more time to log in. So that's
Now?
no.
Do you want to try to put up what you have then? Let me just do one other thing. Share screen.
Oh, whoops.
You have it?
No, something.
Oh. No? Oh, hold on. Now?
Yes, we're good.
Yes, that's great.
Okay, so now you have that. Did it change? The slide change?
Yes.
Okay, and it says I have no financial disclosures?
Yep, you're all
Yes.
set.
So good.
Okay. Hold on one second. Give me one second. Something went wrong again. I am sorry for this. Share screen up.
You're
You're-
muted, Traci. Dr. Burgess.
Do you see anything?
We see the Valley Health System.
All right, so then that should be, that's a start. And let me see. Okay,
So
so I think
if you click on the PowerPoint,
Is it
there
big?
you go. You
Okay.
got it.
All right, sorry. Okay, but a quick get there. So we called this tonight's program Better Health for Black Moms. But before we are moms, we are women. And so I like to just say it's going to be better healthcare for Black women, right? And so I decided to do OBGYN because I love that this field would take care of women across their lifespan. So I'm an OBGYN, and then specifically I'm a perinatologist and maternal-fetal medicine specialist. So I care for the high-risk pregnancy and some low-risk pregnancies too. And we kind of break it down to maternal medical issues, fetal issues, and what we call perinatal issues, things like preterm labor, bleeding in pregnancy, things of that sort. So what is health? So it's a narrow concept to think of health as just not being ill. We like to think of it a bit more broadly, with health being a complete state of physical, mental, and social well-being. And how we are before our pregnancies has a direct impact on how we do during our pregnancies. So health is a state of body, while wellness is an overall state of well-being. And there are many dimensions to what may make one well and what keeps us in balance. So now, what is the issue? Why are we having this conversation, and why is this conversation targeted primarily for the Black mom? Well, for years, we've known that health disparities exist. This citation was from a couple of years ago in the record right here in New Jersey. And it said that 37 women die on average for every 100,000 live births in New Jersey, compared with 20 nationally. So New Jersey's rate's higher. But for African-American women in New Jersey, the rate is 5 times more likely than their white counterparts to die from a pregnancy-related complication. So the hope is, with conversations like this and some other changes that have been happening, that not only will we identify that these differences exist, but that we'll try to make strides to close the gap. So now this is actually an older slide. On this slide, it's showing mortality, and the different color bars are showing different time frames, with the most recent time frame being in the light green. So when you're taught as a resident, the 3 main reasons why women die across the globe: hemorrhage, pulmonary embolism, hypertensive disorders. And those 3 are the main things. And you see that it's a higher risk. But more recently, probably is related to some medical advances, with women getting pregnant older, women having higher BMIs during their pregnancy, some other women with underlying medical problems. What's more common more recently and to this day is that heart-related conditions, a problem with how the heart pumps, some other cardiovascular conditions like stroke, those are now what's leading in terms of pregnancy-related mortality. And so it's said that for every woman that actually dies in childbirth, that 70 women have significant medical complications. So the death would just be the tip of the iceberg, but there would be far more women that have medical complications and other things that may significantly impact how either future pregnancy outcome or how they make it through the rest of how they heal after a pregnancy. But as a high-risk obstetrician, my goal, or our goal, is to try to level the playing field, because we want to identify some of these risks so we can try to limit their occurrence and to try to decrease the likelihood of some of these significant medical outcomes, and to have the most ideal outcome for both mom and baby. So now, if you're really going to address what causes health, it's some of the things at the bottom of the period that relate to some of the societal issues and problems and some other determinants of our overall health as community. But tonight we're going to talk a bit more about this tip of the iceberg, things related to counseling and education, to try to make our differences, to make the difference, I guess I should say. So what makes you healthy? Lots of us emphasize genes and biology, and while that is important, clearly it's our behaviors that seem to have a much larger impact. So classically, you'll think of pregnancy as 3 trimesters, first, second, and third, leading up to the birth. But the concept of the 4th trimester is extremely important. That's the interval after pregnancy, when we still need to be very attuned to how the mom is doing and what her condition may be. So you really need to examine for a pregnant patient what's happened in the pregnancy, identify any risk. Was her blood pressure high or borderline? Did she have some additional bleeding? Does she have a history of some other autoimmune condition? Things that may impact the post-delivery period. And realize it's not just a one-size-fits-all 6 to 8 week postpartum check, but in that fourth trimester, individualize when that woman gets seen and evaluated. Really, we argue that the fourth trimester is almost a whole year after a pregnancy. The other part that's very important is the preconception time period. So ideally, you want to be at your healthiest when you decide you're going to embark on a pregnancy. How you might be managed or the type of evaluation you need won't be the same for every individual, especially if you have some other underlying medical problems. So you may have some general things that we do for preconception care and then some specialized things. So the preconception time is when you want to eat well, exercise, lose your weight, take folic acid, see the genetic counselor, get vaccinated. For older moms, that may be the time you want to get your mammogram, you may have your cardiac evaluation, and depending on the person's individual medical problems, have specialized tailored preconception care plan for you. So at the end of the day, you and your partner can have the most ideal outcome and be at your best at that baseline time frame. So I'm going to quick run through a couple of high-risk issues because the idea was to have some more of a conversation and to be able to ask some questions. But I'm going to hit on the more common high-risk problems. So age. So age is a risk factor that cannot be modified. We're going to get older as long as you're living, right? But with age, it can be harder to get pregnant. It can have experienced more miscarriages and pregnancy loss. There may be higher risk of problems like Down syndrome and some other chromosome changes. And it's more common that people may be overweight, have high blood pressure, higher risk of having diabetes and high blood pressure in pregnancy, even if you don't have that at your baseline. So age is a big determinant in terms of the likelihood to get pregnant and how you may do in your pregnancy. Multiple gestation is another common high-risk issue. So if you have twins and clearly anything more than that, triplets or more, that just automatically increases all the risk for pregnancy, no matter where you're starting at your baseline. When we think about obesity, so obesity is a big preconception risk factor, particularly when your BMI is greater than 30. It has impacts on both the baby as well as the children long-term. It's thought that there may be some other nutritional issues, which is when you have gestational diabetes, that can impact the fetus, and then the programming that's happening to the baby while it's still inside your womb that can affect that child later in life. Similarly, we like to refer to pregnancy as being the natural stress test on your heart. So if you have high blood pressure, gestational diabetes, preterm birth, it's thought that these things might actually be markers or signs that may suggest you're going to have a high-risk cardiovascular profile in the years that may follow your pregnancy. So health problems during pregnancy, even if they disappear, can signal trouble for your heart. It's hard in the midst of the pandemic not to talk about the pandemic. So we've come to see that COVID makes pregnant women get sicker. They have a much higher likelihood of going to the ICU, have a higher likelihood of needing the tube to be placed into their respiratory system to breathe for them, higher risk of prematurity as a result. So the things that we can do to try to slow the spread and protect ourselves from COVID in pregnancy: wear a mask, social distance, wash your hands, get vaccinated, because that has been shown to be helpful in reducing the likelihood of having severe disease in pregnancy as well, and then continue to receive your prenatal care. While for me, choice A, B, and C is to get vaccinated. For those patients that choose not to get vaccinated in pregnancy, it's then very important that your pod is vaccinated. So the people that you live with, and that you really don't let your guard down in trying to do all of these things. But again, we suggest vaccination. Just again, to talk quickly about that fourth trimester, and we're going to talk about it some more. It's very important to know the signs, what to look out for after you've delivered and you've either maybe still in the hospital or you've gone home. Are you having headache, visual changes? Are you feeling chest pain, palpitations? Are you short of breath? Those things might be signs that someone may have high blood pressure issues that may have predated or related to pregnancy directly, that may be associated with a particular type of heart failure. stroke, pulmonary embolism. So it's very important to know what types of symptoms are not normal to experience right after you deliver, and to have a good sense of how the end of your pregnancy was going, so that if you were to experience these things, you can present to your doctor, to the emergency room, and to advocate also for yourself during this 4th trimester. So as I touched on the word advocacy, there's lots of groups out there, all of us trying to do the same things to align, to try to talk about what it is we can do to keep ourselves healthy. And I just gave one portion of a poster from the National Association to Advance Black Birth, but here they talk about the Black Birthing Bill of Rights, and the things that they talk about, that it's important that you have the right to receive care that you can afford, that you have the right to receive care from a provider that may reflect your cultural background, or at least that will incorporate some of your beliefs into your care. That you have a right to choose your providers, that you feel supported during the pregnancy, and that you feel strong and capable, and that someone can help you acknowledge these rights, and that you receive good care, because good maternity care is considered anti-racist care. And so there are lots of people, lots of organizations out there trying to advocate for women of color, but really the whole population as well, to make sure that your prenatal care time, your pregnancy, the time after, addresses your individual needs. So very briefly, in summary, high-risk pregnancy can be a spectrum. There are lots of different things that may make one high risk. That said, we have ways that we can follow you, monitor you, to try to prevent certain type of complications and try to manage it, because our goal is to try to use a multidisciplinary approach so that you have the most favorable outcome for you and your family. Again, as we said, pregnancy is a window to the future. Some of the things that happen in pregnancy may foretell where things may go. So we have to think about it in that aspect. I'm also using this window as my segue to Dr. Williams, who's going to talk to us a little bit about heart health. And if I'm lucky, I will end this slideshow. Let's see. Okay.
Thank you, Dr. Burgess. Elizabeth, is there a way to pull my slides up or no?
Let me see. I have them shrunk at the bottom of my screen. I just am not sure.
If not, I can just speak. I'm not as facile as Dr. Burgess. She's
If I stop sharing, is it done?
I can try to see if there's a, I do have it here. I could try to pull it up on my end if you want me to try.
Yeah, if you just hit the share screen
Okay.
option.
All right. And okay.
Oh,
Does
looks
that
great.
show? Okay.
Yeah.
Good.
Nicely.
All right. So let me see if I can just take a brief moment here to talk about the cardiovascular. You probably asked, what is the cardiologist doing on this presentation? Because it's about pregnancy and giving birth to a new child. But as you've heard from Dr. Burgess, there is some significant connections. And some of what I say, she's already emphasized, but maybe we can just re-emphasize the point for you. So what's cardiovascular risk and consideration for caring for pregnant patients? That's what we want to briefly talk about from a cardiac standpoint. I can just share with you that even today, I had a young lady come in. She's in what we consider the 4th trimester by Dr. Burgess. She's delivered, but she had sort of a rocky course, and she has post-pregnancy diabetes, and her pressures were quite elevated today. So I ended up seeing her in the office and doing some interventions to try to help her navigate this sort of postpartum stage or post-pregnancy stage of her journey. So one thing I just want to reemphasize, cardiovascular mortality is the leading cause of death, even in pregnancy. We hear a lot about heart death, but we usually think about men, especially older men in particular. Women don't normally think about heart disease as an issue, especially young women. but it's really important. One of the things that's a little concerning is that the rate or mortality or death has doubled in the last 20 years. And it may be for some of the things that Dr. Burgess shared, one being that we're tending to have pregnancies at an older age, and sometimes with more risk factors, as which we'll talk about here. So here's some examples of the complications that might occur. So one is coronary heart disease. So that per se is not the highest thing, but what is noted is that often because of the hormonal changes during pregnancy, the lining of the coronary artery sometimes can become very thin, and they can basically dissect, rupture, tear. Just think of it like a stocking that you wear that suddenly tears suddenly. And that can be catastrophic, often associated sometimes with hypertension and preeclampsia. So that's a reason to follow. Unfortunately, there can be strokes. A lot of times they can be related to bleeding, but clotting can occur. High blood pressure is a big issue that we need to monitor. It's not only important just in general, but it also can be a precursor to preeclampsia, which is a very high risk event in pregnancy, and should be addressed aggressively. Usually heart failure can occur. Usually what I mean by heart failure is where the heart muscle becomes weak. It doesn't pump as effectively. It's actually most commonly occurs in the third trimester, or the last 3 months of pregnancy, because that is where your volumes are at their max and the heart is working the hardest. And so it's something in some of our patients we have to recognize. Congenital heart disease. So what does that mean by that? So things like people having holes in the heart, like ventricular septal defect is a medical term, but simplistically holes in the heart, or valves in wrong positions, or valves that are too stiff. The good news is that more and more people who are born with heart problems are living into adulthood. And we have patients who come in who've had these kind of heart issues when they were born, who now want to have children. And so you have to kind of recognize that risk and address it when it's there. It's very easy to know, by the way, if you have one of these, because a simple ultrasound or echo of the heart, which we do in our office, can often determine if the heart is healthy or whether there is some mechanical issue. As Dr. Burgess talked about, there are kind of three phases. There's the pre-pregnancy phase, there's the pregnancy, and then there's the post-pregnancy phase, right? So ideally, you would want to know this during the pre-pregnancy phase. Before you even get pregnant, you want to go to your OBGYN physician or primary care and say, how healthy am I? If I have a heart murmur or something, should I get checked out prior to getting pregnant? So I know knowledge is power. Just the regular knowledge is power. Sometimes aortic disease can occur. Unfortunately, sometimes the aorta can dilate or tear during pregnancy. Arrhythmias are particularly important. That's where you have the heart racing or beating too fast or irregular. Studies have shown, for whatever reason that's not fully understood, but arrhythmias seem to be more common in Black women in particular who are pregnant. So it's really important, if you notice any irregularities in your beat, to get checked and followed up. Thromboembolic is just a big word that means clotting. Clotting issues can sometimes occur. And believe it or not, cholesterol goes up significantly during pregnancy. Most of the time we kind of ignore it, but there are settings, particularly if you have a genetic or gene that predisposes to very high cholesterol, you want to be followed very closely if that occurs. So the risk factors for this, for atherosclerosis, when you look at it, so the non-modifiable ones, Dr. Burgess talked about age and also race. And I put race up there because unfortunately, we know in our country, because of healthcare disparities, that mothers of color have a much higher rate of complications and mortality. So it's just important to recognize that for many reasons, and to just be aggressive in advocating for your own health. In terms of potentially modifiable ones, so high blood pressure, we can talk about the definition of that if people want to know. Smoking is not great. If you're on blood thinners to start before getting pregnant, definitely need to have a conversation, preferably prior to getting pregnant, about risk and how to manage that. That can be very tricky. If you've had heart surgery and you have a valve in place, if you get pregnant or you're thinking about getting pregnant, it's a good time to speak with your OBGYN and possibly a cardiologist as well. Cardiomyopathy is just another word for sick heart or weak heart. If you've, for whatever reason, have experienced that prior to pregnancy, pregnancy is like a stress test. I think on the slide that was shown by Dr. Burgess, it really is a stress test. It's really a way of revealing how fit or healthy your body is. And so if you've already have pre-existing issues, they may be magnified during pregnancy. And at a minimum, you at least want to know what they are so that they can be addressed to navigate this safely. Elevated pressures within the arteries in the lungs is a very dangerous diagnosis. Again, it's usually easily picked up through exam history and also by doing an ultrasound or echocardiogram, which is an ultrasound of the heart. You can usually find that very quickly and address it. Diabetes, congenital heart disease is, as we talked about, a risk factor. Aortic disease, if you have it. And then there's something called connective tissue disease. There are syndromes where people have issues with their connective tissue. That's the elasticity of your arteries and your bones. And sometimes if they are genetically very loose or not that, or too elastic, they can lead to issues like dilated aortas. They can lead to the coronary dissections that we see. So if you know you have that, or if it's diagnosed, clearly you want to have a conversation about that and how to approach it. So what are the critical things? So there's certainly 3 periods we talked about, but before we start, I'm just going to recommend, it's always great to have a team. And I'm sure Dr. Burgess would agree. Often the person driving that team is the OBGYN. I get a lot of patients that are sent to me from OBGYN, and then we work as a team together. You want a physician, and being empowered, you want a physician who's willing to work with a team, who can work with the other physicians so that you can get the best possible help, advice, and directions on care. So that would be a part of that. And then there's the pre-pregnancy evaluation, as we talked about. Are you thinking about having a family? Even if you think you're healthy, it's always good to have a conversation. How am I? If there's any question at all, for example, any cardiac question, palpitations, arrhythmias, heart murmurs, get it checked out before you get pregnant so you can at least know how to think and navigate that. So the second part of that, which is important, is also reducing or protecting the baby or the fetus because of medications you may be on. So that's another reason for that, and to reduce risk. During pregnancy, the thing that I want to stress is the pregnancy is kind of an amazing journey. The body goes through amazing changes. Your volume and your blood volume and all goes up dramatically. Your heart rate tends to go up toward the end. It's amazing what happens, but it is a big stress on the body. And so it's just important to recognize that you might be fine without pregnancy, but especially as you get into the last 3 months of pregnancy, if there's any risk in terms of your health, it may become more pronounced or exposed at that time. Knowing in advance what those are often helps lead to a much better outcome than surprises or a lack of what's going on as you go through that. There's, obviously, I mentioned dramatic metabolic and hormonal changes, and those changes have direct effects on the heart and the blood vessels, which I'm happy to talk about if there's questions in the question and answer section. And then post-pregnancy, I put a prophetic future risk. Generally, what the pregnancy stress test brings out are issues, even if you navigate successfully and do well with the pregnancy, but have some of these issues develop, they sort of predict what will happen later in life as well, not only now. So for example, if you have elevated pressures, there's a link between that and increased risk for high blood pressure when you get older. If you develop diabetes or some borderline changes that may go away, but it may become an issue later in life. So it means that you must continue to always stay vigilant and take note of those changes in your body, because again, if you know, and if you're empowered, and if you're tracking, it can help to alter your outcome in a really favorable way, and you don't get surprised by some of the things that you see. So that's why if you go to see a cardiologist like myself, and I ask, was your pregnancy normal or not? And you say, what's the cardiologist asking me that? I've come for something else like my heart. Well, the reason we ask is because there's a link between the course of your pregnancy and predicting what might happen later in life with your heart. So that's really important. So I thank you for that. I just happy to answer any questions along with Dr. Burgess, and appreciate the opportunity to speak with you.
Thank you, Dr. Williams, and thank you, Dr. Burgess. Dr. Williams, if you want to stop sharing your screen, I think we'll see both of you at the same time. Okay, there
How do I
just
do? Oh, here we go. I see it. Great.
just a couple of questions. And I think you kind of addressed this, but just in a more, if during the 4th trimester, if we're at higher risk, what sort of symptoms should you be watching for in the 4th trimester? So after the baby's born, for healthy.
So I think probably one of the bigger ones, sometimes what you look out for will depend on parts of how your pregnancy goes, but I'm gonna give a couple of examples. Probably for everyone, you should look out for symptoms that may suggest your blood pressure is up. So as we know, people talk about you may not have any symptoms when your blood pressure is elevated, but some women will have headaches. They may have visual changes. You might feel almost like an indigestion that doesn't necessarily go away or doesn't seem related to food. You have some of those symptoms. That'd be an important thing to look at. While we talk about preeclampsia as being a condition where your blood pressure goes up in pregnancy, and there's some other changes that can occur, a portion of people after delivery will also develop preeclampsia. So when you are attuned to the fact that you're having some of these symptoms, you should get a blood pressure check. Call your doctor, get a blood pressure check to try to see. If you were delivered because your blood pressure is borderline, or they use words like gestational hypertension, preeclampsia, and again, you're feeling some of these symptoms that may be headache or chest or discomfort in nature, again, you want to get a blood pressure checked and you want to call and notify your doctor. Sometimes people get short of breath and a sense of anxiety. That may be a sign that you have a blood clot. Pregnantly, because of all the hormonal changes we just talked about, because of some other the mechanical changes, because you have this big pregnant uterus for a portion of your pregnancy that's pressing on some major vessels, the way the blood flows through your blood system, frequently through the lower extremities, but some people may have an underlying predisposition to clotting that they may not be aware of. You can get blood clots, and the blood clots can travel to your lung, and one might feel a little bit anxious or feel a degree of shortness of breath. So those are the kind of symptoms that you would want to call your doctor about. Separate and apart, some people may also have other mental health changes. They may have more than just the baby blues. That typically may not be early in the first couple of days or weeks after pregnancy, when you're tired and you're trying to adjust to all the different changes that occur, and that may occur a little bit later on. So again, if you think of the 4th trimester as delivery through that first year, there can be various things that may not exactly feel quite right to you that you should bring to the attention of your doctor. Now, I'm saying your doctor because ideally you should try to touch base with your obstetrician gynecologist. That said, if you go to an emergency room or if you see a family practitioner or an internal medicine person, it's important that you share with them, I just delivered at this date and this time, and share some of the aspects of what happened in your pregnancy, because they may not think about that first if they're not aware that you recently had a delivery and it's not brought to their attention.
Thank you. Actually, I'd just like to remind people, if they do have questions, they can submit them in the Q&A portal at the bottom of the screen. Dr. Williams touched on this briefly. If I have gestational diabetes, will I need to still be treated for it after my baby is born?
So that's a great question, and I think it varies a lot of times with gestational diabetes. Post deliveries, it may actually improve or go away. So it's just what's important is just to keep an eye on it. It varies. Some mothers it goes away, some of it persists. But also to recognize that even if it does go away, you may be at risk later for it reoccurring. The treatments are sort of similar. I mean, Dr. Burgess can help me out on this, but I think the treatments are kind of similar in the sense of, in terms of besides medicine, is really working on getting, making sure your weight doesn't go up, keeping your weight down, eating healthy, and I guess to the extent that you can, exercising, because a lot of times that will get things back to normal fairly quickly if you're able to do that.
What I'd like to add is just that, remember, in pregnancy, you have a new organ. This organ is the placenta. And the placenta is a big dynamic factory, just doing all kinds of things from a hormonal perspective. And one of those things can make you a bit more insulin resistant. And so it's not uncommon that after you deliver and the placenta is removed and you start to go through the normal physiologic changes to become a non-pregnant person, that those sugar values may improve. And that's one of those things that may get better. So sometimes even in the hospital after you deliver, your docs may not necessarily even check your finger stick, but it's imperative, it's very important that roughly 2-3 months after you deliver, that you get screened then, because then you can get a good sense if you're pre-diabetic or what's going on. And then, as Dr. Williams said, you want to now make sure that you get physically active. I think physical activity is probably one of the keys to longevity in general. So you want to get physically active. If you gained extra weight in pregnancy, you want to make sure you lose that weight. We typically suggest that the average size pregnant lady, so someone with a BMI less than between like 17 and 25, 19 and 25, gain about 20 to 25 pounds in pregnancy. If you have a BMI that's higher, you don't need to gain 30, 35, 40 pounds. You probably are okay if you gain 10 to 15. So if you've gained a lot of weight in pregnancy and that interval in between, losing that weight, becoming physically active is one of the main things you can do to try to minimize that risk of diabetes in the future.
What tests are recommended prior to starting a family?
So I think a basic good physical is good. So you want to have somebody check you from head to toe to kind of go through, to also review your medical history, your family history. You could do a genetic screen and a genetic history as well, because we're learning a lot more about genetics, and there are more panels and things that are out there to see who carries what types of conditions that could potentially affect a future pregnancy. So going to a general OB/GYN, going to your internal medicine or family practitioner and tell them you're interested in getting pregnant, so that they can, depending again on age and size and some other things, determine based on your individual needs. Do you need to have the sonogram of your heart that Dr. Williams talked about before? Do you need to have a screen of your sugar beforehand? I find that if we can get somebody seen ahead of time, if you identify some things where they may be borderline, like borderline diabetes, and we have a time frame of even a couple of months before someone's actively trying to get pregnant, that's a better place to be than now addressing the abnormal hemoglobin A1C or the elevated blood pressure, but not on medication in the earlier part of pregnancy. So we will work with you, and clearly we will try to manage whatever we get. But if we can see you in those 3 to 6 months before, to then try to make some of these changes. And then if you happen to be someone with, as Dr. Williams suggested, an underlying cardiac problem, a seizure disorder, issues with depression and anxiety, whatever the body system may be, if you have a medical condition, that's an excellent time to see your general doctor, your specialist, and an OB or MFM person, so we can tie it together. He talked about team. In one of my slides, I talked about a multidisciplinary approach. When you get your team together, then we can figure out what's the best way to manage you for the pregnancy and beyond.
Okay, what is the recommended BMI to be in prior to conceiving?
So if your BMI is less than 25, that's ideal. For those whose BMI may be a little bit higher, it doesn't mean that you can't conceive, and you very well may get pregnant spontaneously, but as our weight goes up, it can become more difficult to get pregnant, and there's some other additional medical risk factors. If there's more to that question, I can add to that.
Okay, next question, what is MFM?
MFM stands for Maternal-Fetal Medicine. So it's one of the specialties of obstetrics and gynecology. So I did a general training in OBGYN, so care of the non-pregnant woman and care of a woman in pregnancy. But then I did an additional couple of years specializing in pregnancy and all aspects of pregnancy. So I take care of the mom with maternal medical issues. I take care of the baby. We also take care of people without issues. We make sure things are going well, but MFM is that specialized division of obstetrical care.
Okay, where should you get an MFM? When should you get an MFM? I'm sorry.
So that can be a bit of a complex question. It depends. So it depends on what your issues may be. And it kind of may depend also where you live and what happens in the geographic area where you are. So if you have certain identified high-risk issues, either things that predate pregnancy or things that occur during pregnancy, it's not uncommon. You might have an interface or an interaction with maternal-fetal medicine specialists. There are some maternal-fetal medicine specialists that do complete obstetric care. So they would do from your first visit to the end, they would manage your delivery. There's some that just manage aspects of your care, so it kind of depends. Typically, if you have very high risk issues, so that's the person with the transplant, that's the person who has long-standing diabetes with maybe some underlying renal conditions, some other prior history of stroke. Those types of patients may solely be managed by a high-risk OB. Frequently, the high-risk obstetrician is a part of the team that your OB doctor will work with. So most facilities that have labor and delivery units, a part of them, have a maternal-fetal medicine specialist on staff or with quick access to get them if necessary.
Okay. Okay. Another question. According to the New Jersey Department of Health site, Valley has a high rate of C-section deliveries, and only 2.8% non-Hispanic patients. Should I be concerned as a woman of color delivering at Valley with these percentages, considering the high rate of maternal mortality for women of color in New Jersey and the known complications from C-section? Is anything being done to lower the C-section rate at Valley, as it is higher than the US national average of 31.8?
So there are many different things that go into why someone may end up with a cesarean delivery. And sometimes it also has to relate to a combination of patient choice, physician choice, and the clinical circumstances that are going on with it. Why it's good to know the numbers, why it's good to know what you feel, and your history and things of that nature, is that you can now advocate for yourself when you have your conversation with your general OBGYN and are talking about what your pregnancy looks like, what your delivery may look like, and what those conditions may be that may lead to someone needing a cesarean. So some things are going to be by cesarean no matter where you are. If the placenta is in the wrong location, it's covering the opening. Certain patients with very high blood pressure, all those things may lead to ultimately having an operative delivery. There have been initiatives across the country, in our state, in our institution, that look at and examine deliveries and why they occur and how, and the mode of delivery and how they occur. So yes, there's always conversations about what's going on and reviews of the cesarean rates and some of the reasons why they may occur. The other part that can be hard to tease out sometimes when you look at general numbers for any individual institution as well, you have to take into account sometimes the mix of the patients. And so the age of mom sometimes will come into play. If there are multiple gestations will come into play, the underlying medical issues, the patient desire. So it's a complex kind of an issue, but there's lots of attention nationally and locally to try to make sure that the care is the appropriate care. It's hard to know what a right number is because people always argue, what is the right number for a cesarean? And that's still yet to be determined, but lots of things go into looking at the benchmarks and trying to find out where we are and to drill down to see what's going on with many of those cases.
Thank you for answering that. I'm seeing if any other questions are coming in. It doesn't look like it, but I want to thank both Dr. Williams and Dr. Burgess for your time this evening. And before I do a closing out, do you have any final recommendations from either of you?
Well, I think what I'll just say first, try to, again, go back to that whole sense, one of my earlier slides about wellness and finding our balance. I think that's important. I think it's important for you to know your own medical history. So this way, when you go and you interact with the healthcare system, you have as much information that you can bring as a part of that conversation, and then continue to advocate for our health, the health of our communities.
And I would just add to that, that it's really important to try to be as informed about your own body as you can, and your own risk and your own health. As I've just said before, knowledge is power. So really through the help of your provider or your OB doc, is you want to know as much about your own health, because the better you understand it, the more you can advocate for yourself and advocate for what's there. So you do want a healthcare provider who can help educate you in a way that you feel like you really understand, that you can then begin to make choices for your body based on wise decisions by someone who's helped you to figure out what the options are. So that would be my only other thing.